Morning. It's just after 9:30, so we'll make a start. I'm Dennis Morrison, one of the organisers of the programme on infectious dynamics of pandemics at the Isaac Newton Institute in Cambridge. And this is part of a series of a workshop on future pandemics. And this morning we're going to be hearing from experiences of two islands at opposite sides of the globe, their experience of the pandemic and what we can learn for the future. So we'll have the two presentations with any immediate questions after each one, followed by half an hour of general discussion. So first of all, very pleased to introduce Michael Baker, Professor of Public Health at the University of Otago, and has been had a leading role in New Zealand's response to the pandemic. So Michael, if you'd like to share your screen, without further ado, the floor is yours.
Yes, thank you, Dennis, and it's a great pleasure to be participating in this Future Pandemics workshop. So I'll just share my screen now. So this morning I'm going to be talking about the elimination strategy for responding to COVID-19 and the experience from New Zealand. So just a bit about my own background. I have had some previous experience with pandemics. In fact, my experience with working on the HIV/AIDS response in New Zealand really got me very interested in the organised efforts of society, and I switched from clinical medicine to public health medicine. And one of my first roles was setting up the needle exchange program in New Zealand, possibly the first national program internationally. And then I had some role in SARS, but it barely affected New Zealand. But then pandemic influenza in 2009, and of course COVID-19 this year. And I think the experience of probably most infectious disease epidemiologists internationally is that we've all been extremely busy for the last few months working on this. And this morning, I'm going to work through 5 broad areas from the New Zealand experience. Firstly, assessing pandemics, the strategic choices for pandemic responses, the components of the New Zealand elimination strategy, what effect has this strategy had in New Zealand, and what are some of the lessons that can be generalized from this experience. So looking at the sweep of pandemics, the history we have of these events, I've found there are 5 recurring themes. These are that they often have high impact on population health and social and economic well-being. They generally increase inequalities. There's usually uncertainty and unpredictability, particularly at the start. They're often more controllable than we might think. And that's really a question around risk assessment, risk management. And there's often panic and outrage. So just reminding us of the basic terminology, will be very familiar to, I'm sure, all of us. The core idea of an epidemic being more than expected, outbreaks being localized, and pandemics widespread, generally affecting multiple countries. Of course, if this Venn diagram was to scale, pandemics would be a tiny little pinhead here because they are fortunately rare. So one thing is that we can think about this idea of a typology of pandemics. We're familiar with pandemics that are transmitted between people with short to medium incubation periods. And that's generally what we think about pandemics. And influenza really has featured so strongly in thinking about pandemics. It's almost defined the approach in this area, which actually can be a problem because it's been such a dominant paradigm. And of course, we have now the suite of coronaviruses, and then on the horizon, the synthetic or weaponized infectious diseases. And there are other categories of pandemics, and I've just identified those that have met the threshold for being public health emergencies of international concern. And that's obviously a designation with the international health regulations, but I think it does identify events as really meeting a threshold for being of concern to multiple countries. And the other group here are pandemics, where there's often asymptomatic transmission and long incubation periods. And it's interesting to think how HIV/AIDS would be viewed if it emerged today in terms of a pandemic. And one of the reasons for thinking broadly is that approaches that I'm going to talk about, which is elimination, can potentially be applied to all of these categories. We also have pandemics which are predominantly transmitted from animals, vectors, and food. And this includes also some public health emergencies of international concern, like Zika, for example. So when we're looking at pandemic threats, we often have a lot of certain parameters that we will focus on. And often we'll focus on the reproduction number and the case fatality risk, for instance. But this is quite an old graphic from a paper from a few years ago, but I always found it was quite a useful thing to think about, because it added this dimension of the percentage of infections that occur prior to symptoms, so pre-symptomatic or asymptomatic infection. And they proposed that the controllability of pandemic diseases was often related not just to how infectious, but also the extent of asymptomatic transmission. And of course, it's obviously important, but they were pointing out why a disease like SARS was relatively controllable, whereas on this same scale, we probably would have COVID-19 more in this realm here, where it's becoming less controllable because of this proportion of asymptomatic transmission. So when we look at all the factors for assessing a pandemic, we would look at obviously the impact, particularly case fatality risk, and what we really want to know, the infection fatality risk, which is not always easy to get at the beginning, the transmissibility and the R0, but often we really think about the effective reproduction number, because there's almost always some control measures being put in place. And a lot of these things then, as we've discussed, affect the controllability, which I think is a key question that is often uncertain at the beginning. And again, the certainty of information, even the effective experience and dogma, and things that constrain thinking at this stage, the feasibility of the response, the economics, action, inaction, and often the counterfactuals that we put forward, and of course the impact on inequalities. So in New Zealand, as I think most countries around the world did in the early stages of the pandemic, we modeled the likely impact of a fairly poorly controlled pandemic wave. And initially this was done in February and March of this year. And you can put in some fairly likely values, and you can work out that this pandemic would, we thought our most plausible estimate was this number of fatalities, about 0.3% of the population. And this could be equated to roughly 25, the mortality from 25 seasonal influenza seasons, because we've had good estimates of the modelled mortality in New Zealand from seasonal influenza. And that was a way of trying to communicate that this was not just a bad flu. One of the big drivers of the response in New Zealand was concern for inequalities, and particularly Maori versus non-Maori in New Zealand. And we have a treaty relationship with Indigenous people in New Zealand, the Treaty of Waitangi, and that's a big driver of health responses. And we can see over a century of, including 3 influenza pandemics, the rate ratio for mortality was still significantly higher for Maori versus European and other. And we hypothesized that this would also apply with COVID-19. So when you're thinking about choosing a response, one of the frameworks that has now been around for about 3 decades is the concept of being on a spectrum of control and elimination. And obviously elimination is, I mean, to some extent, all infectious diseases have some degree of control. So elimination is a higher bar, and there's certain requirements for that to be considered. and eradication is just the global equivalent of this, reducing to zero at a global level. So I think, like most, good and bad things, we sometimes remember where we were when we suddenly decided that they really were important. And I think I know I remember these light bulb moments with COVID-19, and I think the first one was probably what a number of people had in late January, seeing this number of estimates or assessments, and this one I thought was particularly helpful, saying this was going to be a serious global pandemic. The next moment for me was really looking at this joint report from the WHO mission to China, saying that actually this pandemic could be contained, eliminated, stopped. And that really said it was more like SARS and less like influenza. And then in March 2020, we were seeing the pandemic wave hitting New Zealand, and the evidence that it was transitioning to community transmission, that we did not have the infrastructure to do contact tracing and testing and so on. So basically we concluded that a lockdown was needed. So this is, sorry, it's a rather busy slide, but this is trying to point out that countries have these strategic choices. And when you're planning and looking at assessing a pandemic threat, you can look at an exclusion strategy, which applies to some Pacific islands, and it's still the case that there's 10 Pacific islands that have no cases at all. We've got the elimination strategy that New Zealand had adopted, but of course, we went into the pandemic with a mitigation approach, which was in our pandemic plan. It's all about flattening the curve. And we realized that this was going to be very destructive, so we switched to this elimination strategy. I know many countries have, in Europe typically, have taken a suppression approach. And of course, some countries have no substantive strategy. The benefits of elimination exclusion, of course, is that you may be able to, particularly for elimination, return to a carefully managed new normal, a very overused expression, within 3 months. And this was the experience we were seeing in Asian countries. And we thought the alternative was less attractive, which was the idea you have prolonged control measures until a vaccine or antivirals were available. And then, of course, a mitigation approach, and even framed, of course, as herd immunity at a certain point. So we worked and wrote an elimination strategy for New Zealand, and this was adopted by the New Zealand government. They didn't really want to call it elimination at first because that seemed too difficult, but they did go for this decisive approach for a rapid lockdown, and a decision made on the 23rd of March when we only had 100 cases and no deaths at that stage. So one of the components of elimination strategy, well, it is fascinating to see the reproduction number become a household term. And this is obviously has a number of forces that drive it. Now, duration, of course, is something you'd like to be able to influence, but you can't without antiviral treatment or some other means of reducing infection. So you're really left with just two fairly crude instruments to try and reduce contact rates and reduce transmissibility. And so many of our interventions feed into these two drivers of the reproduction number. So the components of the elimination strategy in New Zealand essentially was exclusion of cases, so keeping it out at the borders. Case and contact management, this is the stamp it out terminology. This is from our influenza plan. And trying to reduce transmission, reducing transmission per contact and reducing the frequency of contacts. So I won't go through all the details of border management. There's a whole lot of measures, but one of the main ones was simply exclusion. So you couldn't come back into New Zealand unless you were a New Zealand citizen or family member or an essential worker. And also you had to go through managed quarantine and isolation, 14 days with testing at day 3 and 12. So that did seriously reduce the number of people coming to New Zealand. And there were these amazing days when no one came into the country or left the country, and people had to look back through their record books for decades to find another time like that. So the other key strategy was testing and contact tracing, and we, like many places, went from very low numbers of tests up to the point where we could do 25,000 tests a day, and so quite a relatively high rate by world standards. The other big component, and don't worry about the details of this slide, but this was the 4-level alert system that was introduced into New Zealand, which turned out to be a very effective form of risk communication with the public. So everyone now knows what these different alert levels mean, the risk assessment, and just how different life would be at level 4 or level 3. Essentially, level 3 and 4 were both equivalent to stay-at-home orders, and that level 4 is just a bit more stringent. And level 2 has a whole range of measures. We're now suggesting it needs to be made more, subdivided further to be more useful. And level 1 had only border controls. So New Zealand went rapidly into a level 4 and then a level 3 stay-at-home order. I don't really like the term lockdown, but that seems to be the term that's used most in New Zealand by the media. So our level 4 was the most stringent, I think, control measure introduced by any country, and this is using this very helpful Oxford University stringency index. So at level 4, this is rush hour in our capital city, and some of us would get on our bicycles, cycle around town, and you see these really remarkable views that will probably never be repeated, or hopefully not. So the impact of the lockdowns was very striking in terms of the effective reproduction number. Went from around 2 to under 0.5 at level 4, and somewhat under 1 at level 3. So hard to estimate at level 2 because there was just so few cases. So basically 7 weeks in this intensity basically extinguished transmission in New Zealand. And this is a paper we published in the New England Journal of Medicine. They have these COVID notes sections where you can publish these very succinct summaries of what your country's done. And here you can see the bands of control measures and the declining epidemic curve. And initially, our cases dominated by overseas travel, and then switching to local transmission, and then being extinguished. And these remaining cases being reported are those coming from overseas, but they're in managed isolation and quarantine facilities. So when we look at the impact of the elimination strategy, this is showing the one crude metric, which is COVID-19 deaths per million population. And New Zealand has got the lowest mortality in the OECD, still at 4 to 5 per million. And this is markedly less than the OECD average, and also of some other countries in Europe. One of the other things we were very interested in looking at was the impact of the lockdown and other measures on all-cause mortality. And what we found, and this analysis was done up to June, was that, and that included the whole lockdown period, was there was a significant 5% reduction in all-cause mortality. We don't have all the categories. We have some which included road traffic crashes were down. Suicide, interestingly, was down. We weren't sure what would happen there because some people have lost their jobs, and that's certainly a risk factor. So this was reassuring. It doesn't mean there will be health impacts, but the acute impacts seem to be actually minimal. And our excess winter mortality is largely gone, and our influenza mortality has dropped hugely. We haven't done a detailed economic analysis, but this is just comparing with one metric, which is essentially people in paid work, comparing New Zealand and Australia. And we often compare with Australia, well, for many reasons, but one is that they are quite a bit like us, and they had great success with elimination in 5 states, but had ongoing transmission in 2 to 3 other states, their most populous ones. So we were seeing that actually after containing and then eliminating COVID-19 in New Zealand, we actually saw full employment in New Zealand. It was partly, of course, subsidised by government support, so it's slightly artificial, but it was still positive. So one of the key components of the elimination strategy is, of course, as we knew right from the beginning, was resurgence planning and management. And we were, after slightly over 100 days, of course, it was a shock to wake up and hear the news that there was a family cluster in Auckland on the 11th of August, so just over a month ago. So that has formed a small cluster of cases, and I'm hoping that you can see that all right on your slides, that I'm not obliterating my image. I can see that I'm obliterating the image on part of the image on my display, but we've seen this small resurgence in Auckland. It's now coming under control after a month, and we're using very high levels of testing, contact tracing. We're trying to use stamp it out without resorting to a level 4 lockdown, and in fact Auckland has had only 2 weeks of that intensity of lockdown, and this is the far more targeted approach which appears to be working. One of the other changes is we've now introduced mass masking in many indoor environments, particularly on public transport. It's still not part of the New Zealand culture. People are taking some time to get used to it, but we've now got, it's now mandatory on public transport, and essentially uptake is very close to 100%. So what are the key lessons from COVID-19 elimination in New Zealand? Well, one of the main ones is that effective science and good political leadership seem to be a very good combination. And Jacinda Ardern has been is famous for her very empathetic communication style, and she also really understands science. So she has been great at leading the country and making, I think, astute political judgments, and has listened to the scientists, which, as we all know, you can't always guarantee. So there are a number of scientific questions which are very apparent in New Zealand. And one of the ones that we're researching now, of course, is the circumstances when elimination is optimal. And that's compared with alternatives such as control, mitigation, suppression, and trying to look at this both in health and economic terms. There is a question around how you define elimination. We've got a working definition, which is the absence of detected cases for a period, and we're using 28 days, where modelling shows that you've got, if you have no cases at that point, you've got a 95% plus probability of having no more transmission in the community. You can extend that to 99% certainty, so that is obviously what we would tend to do. But of course, the other proviso, it has to be in the presence of a high-performing surveillance system. That's with, in the New Zealand case, would be 5 to 10,000 tests per day of a fairly representative sample of the population who have symptoms. You also have to have exclusions, that is, cases who are identified at the borders and placed into effective isolation or quarantine. Other questions for us have been around the disease reporting conventions. And one of the things that's quite unusual in a way is that the reporting system to the World Health Organization just lumps all cases together. So the convention is, if you diagnose a case in your country, it's added to your total. So we recently saw there was a travel advisory from the United States saying, don't go to New Zealand. This is when we actually had eliminated COVID-19. They have ongoing transmission. They're getting cases most days, which is true. But they were cases in returning travelers who were in very secure isolation quarantine facilities. So they were not contributing at all to risk in New Zealand, but they still appear on the daily total. So this is something I think that could be fixed quite easily. We have, there's really interesting, or a lot of work being done in New Zealand on trying to look at key technologies around surveillance systems. Genomics have been extremely useful. We're looking at wastewater testing. It hasn't really been applied very much in New Zealand. There's a lot of work looking at digital tools to support contact tracing. We're interested in the experience in Ireland of using Google and Apple systems. We've also got a Bluetooth system, a COVID card, which has been developed locally, and it's now, I think, a similar systems in use in Singapore, which are Bluetooth enabled card. This is just a test model, which again is quite, has great potential for contact tracing. The face masks and covering technology, I think, still needs more work, and we're always thinking about the alert level system and how it can be made as a better communication tool. And there are other things also on this list. One of the, I think, key lessons from elimination of COVID-19 is just a reminder about the remarkable benefits that can come from potentially eliminating pathogens. And we've always got pandemic diseases, and the question is, I mean, we've got our disease X scenario now, which is with COVID-19, but even pandemic influenza in the future, obviously diseases that have been eradicated, others where there's global eradication underway, and various regional elimination approaches. And we think probably particularly measles and rubella has been an active area, and other diseases where elimination's been proposed, and looks like it's is technically feasible, particularly in high-income countries. So there's a lot of institutional lessons about how we do business and how the health sector works, and public health in particular. Our conclusion at the moment is that elimination provides benefits to health and the economy compared with the counterfactuals. We really think effective risk assessment and decision-making is vital in these crises. Countries that have responded very rapidly to this threat, I think, have done very much better than those that have delayed responding. Again, equity and partnerships seem to be really important, particularly when you have clearly disadvantaged populations and marginalized groups. It's vital not only for their well-being, but also, I think, for the collective good. And we've seen examples like Singapore, where their response, I think, was really derailed in many ways by them not paying enough attention to migrant communities and their needs. Certainly, this crisis has illustrated the importance of public health infrastructure. And I guess, like many countries, this infrastructure had been generally eroded and fragmented, partly because of the pressures from healthcare services, which are often seen as more pressing, and also the need to strengthen and reform global health agencies like the World Health Organization. So the other lesson, which I think goes way beyond pandemics, is the idea of the broad reset that is needed, and increasing our focus on managing other global health threats. And one of the benefits, I mean, you always want to see, I hope that there's a silver lining in this global crisis, is that it will give more agency to countries and encourage a more collaborative approach. I mean, that's the optimistic scenario. So again, I just want to acknowledge the other agencies and funders here, and particularly my colleagues who are listed here, who have contributed hugely to this program of work. And this is just a graphic from New Zealand. We had a referendum to try and find a better flag. It was a dismal failure, but it did produce some amazing graphics that we've managed to repurpose. And this is a kiwi with, of course, a laser ray shining out of its eye. And over time, it's wound up zapping quite a few different things. And of course, the coronavirus at present is its present target. Thank you.
Thank you very much, Michael. That's pretty comprehensive. So I'm not sure if we have any questions lined up yet. I haven't had any passed on to me. So just ask a rather boring one, but I've always had an interest in sort of spatial geographical spread of disease. I just wondered, in the main outbreak in New Zealand, how widely did COVID-19 get spread, and was that just stopped by travel restrictions?
Yeah, well, New Zealand had, and there is a lot of genetic epidemiology that's been done to describe the arrival of this virus in New Zealand. And my colleagues, we've been collaborating on this, have published a very nice analysis of this. But it basically, the virus came in with tourists, and there were many introductions of the virus in really late February, March. And many of the introductions, of course, it didn't actually generate long chains. In fact, it was interesting, only about a quarter of the introductions actually started what became significant clusters. But they were distributed all around the country because tourists go all over New Zealand, and they actually go to the places that where many, they are sometimes the majority. So they seeded the virus throughout New Zealand quite swiftly.
We are a bit ahead of time, but I think it'd be nice to have more time for general discussion, and I hope the questions on that will come flowing in. So I've got a question from Michael saying, is elimination sustainable in New Zealand without vaccination? And have you looked into elimination strategies that do not limit constitutional rights, such as religious gatherings or right to demonstrate?
Yes, well, that's an excellent question, and there is a tension, as you know, that elimination requires a very intense approach, and it is interesting to speculate on what the necessary preconditions are for elimination to work. I should say it's hugely supported by people in New Zealand and all our politicians, because they have seen the benefits. And actually, some of the major supporters of elimination were actually the business leaders, because they decided, looking globally, that the best future for business was actually having the certainty of having no virus. And when we were confronted with, in a very short period of time, trying to decide what to do, we actually looked east rather than west, because by this stage we were seeing what the pandemic was doing in northern Italy and what it was starting to do across Europe and North America. And the country we really looked to was not only mainland China, which had done obviously remarkable control measures, which was required probably, I think, suppression of a lot of human rights, but we were particularly interested in the Taiwanese approach. And we've actually just got a paper about to come out in one of the Lancet journals. We've done a detailed comparison of Taiwan and the New Zealand response. And I think what Taiwan did was they actually started much earlier, and they had very good infrastructure, and they started, and they didn't require lockdown at any point. So they are, of course, there is some compromise of human rights there, in a sense that there are requirements, for example, to wear masks on public transport, even when there's not been circulating virus for more than 3 months. They've passed a law requiring that. So in the period when we had 3 months of no circulating virus, we were at level 1. There was no restrictions on events at all. We went back to having stadiums full of people, and you could say in a way it was life as normal, except for the borders. So there was no, you could argue there's no compromising religious and other gatherings. When we've got circulating virus, then there are quite severe constraints on normal life. And that, I guess, is the compromise, that the trade-off. And not everyone is comfortable with that. Our laws have been changed to support this. I mean, we already had laws. Most countries have laws that they've probably inherited, which are pretty draconian and would be written differently now. But even then, we had a very old Health Act, but it has had to have many amendments to support the lockdown measures, which are very tough on people. If you think about the number of, I mean, typically in New Zealand there would be 30,000 deaths a year based on given our population. When you think about that, means a large number of funerals, almost 100 funerals every day, and these are people who would normally be honoured by many people turning up for their funeral and being told, look, you can't have a gathering, or it's got to be restricted to 10 people. So this meant that having lockdown measures initially for a couple of months meant a lot of people missed really important family events. And so I think there is a big price for eliminating the virus. And it's not borne equally, and I think it's tough on businesses. And so part of the social contract in New Zealand has been a huge investment in wage subsidies and also schemes to support businesses. So that's a very long-winded answer, but I think it's why the response has needed a very intense all-of-government approach.
Yeah, I think it does depend on the balance of how much you have to achieve by rules and how much you can get your public on side. And I saw the talk by Audrey Tang on Taiwan. Yes. I thought it was very impressive the way they had got public engagement in it and get the public on side, because no amount of rules really is a good substitute for getting your population to understand the risks and behave in a way that minimizes them. Anyway, thanks very much for that, Michael.